Welcome. I am Dr. Patrice Berry, licensed clinical psychologist, and here I share legal and entertainment news from a psychological perspective. Today, we are talking about a difficult topic. We are going to be covering mental health civil commitments. So, people being court ordered to receive treatment. And because of a case that I recently covered, Dejan Anderson, where we're not sure, is she truly psychotic? Is she delusional? Like we're not really sure what's going on. I'm also going to talk about how psychologists assess for malingering or feigning of symptoms without giving too much information, because some of the information is definitely protected. But I think we definitely can talk about these topics. Let me know if you all have questions as we go. Thank you to the subscriber that recommended the Hunter Graham case. There are multiple cases very similar to this that have kind of come up. And we are going to dive right into today's topic. Welcome. All right, let's go here.
The tricky question, of course, is how to get people with mental illness the help that they need if, in their mental illness, they're convinced they don't need help. It's tricky because you're talking about the most precious thing any of us has, control over our own bodies. It's a carefully protected right, but right now, it's so protected, it often seems impossible to do anything for those folks. And so they continue to live on our streets. Our Evan Watson has shown us how many in the mental health field now believe the bar has been raised a bit too high, that it should be easier to force people to accept help. And the hopeful part of all this, the justice system is beginning to come around in Oregon. Here's Evan Watson with the details on Oregon's new civil commitment work group.
Terry Archuleta's sister Deanna died this fall. She lived with bipolar disorder. Archuleta says her sister's mental health had deteriorated in combination with addiction. She wouldn't agree to treatment or stay on her medication.
She was found in her tent in a camp by herself. And that's the hardest part because you always think you're going to have, I'm sorry if you always think you're going to have another chance or more time. And I wish I would have had someone to just take her, because I think on that last day that she was here, if I'd had a place to take her to get sober and be on her meds again, I do believe she would be alive right now.
And so the very difficult thing with cases like this is that people have the right to refuse or decline treatment. And the thing that will come up with a few other cases where they were not only a risk to themselves, but they were also a risk to others. And sometimes the court system doesn't step in until it's a bit too late. And so let me go on ahead. And this in this segment, they're kind of talking more about the unhoused, so people that maybe end up on the streets. That's not necessarily the part that I wanted to focus on. I wanted to focus on if there is a young adult that when they turn 18, they then have the right to refuse or decline treatment, and how families, how people can support people in these difficult situations. Let's listen to a little bit more of this before we get into the case of Hunter Graham.
Isn't alone. There's a growing public awareness that something needs to change. Now, state leaders around Oregon, from lawmakers to judges to doctors and mental health experts, are taking an in-depth look at civil commitment. The group plans to meet each month for the next 2 years to research, discuss, and craft changes to the Oregon standards for civil commitment and forced mental health care. Multnomah County Judge Nan Waller is part of the group, which was organized by the Oregon Judicial Department. She says the group is reevaluating the entire statute to create systemic change.
Because right now the standard is imminent risk. And imminent means like within the next maybe 24 hours. It's not a more prolonged risk. So it's not, we can see that they're deteriorating. We can see that there's trouble around the corner. imminent risk, and that's the standard that Oregon had at the time of the filming of this. So this is about a year old. And so we will listen to what this judge has to say.
I think because we are seeing so many people who are struggling, we see that on the streets. It's covered by the press a lot. People have a lot of personal experience with it. It seemed like the right time for the judicial branch to step up and say, we will try to convene a group that hopefully can come up with some agreements and some better ways of doing this.
Waller's
All right. So there's a great question. Y'all know I love the chat. Allison, so how do you force mental health care? And I'll go more into this on the next case when we talk a little bit more about Hunter Graham, because sometimes an individual can be court ordered to be compliant with medication, or sometimes people they are admitted to a psychiatric unit for stabilization for a short period of time. Some people, they might be admitted for a longer period of time. So the case that kind of comes to, and I'm going to look up the case that this one reminds me of while this plays.
says she hopes Oregon builds a system where people have access to better treatment and receive treatment precisely when they need it. The plan is to take 2 years to develop a report that could change Oregon's commitment standards. When asked why not sooner, Waller said this topic and finding consensus is complicated, especially when considering civil commitment.
These are complicated subjects where people have strong positions. And in order to come to consensus on any change, I think that it is going to take time and full examination. Trying to do a little bit of change along the way, we want to take a look at the whole system, because our concern is that small changes are not going to end up with the results that the community and individuals who have serious mental illness need.
This focus on civil commitment has gained steam in recent months, illustrating a change in perspective. Portland Mayor Ted Wheeler recently told business owners he would support a hard look at the legislative level of our involuntary commitment laws, saying people need help and compassion, especially when they're homeless after refusing recommended treatment. Currently, the work group is reviewing civil commitment standards in other states to see if they would adopt something that works better.
And that's where I hope that it's not only about homelessness, that it's also about taking a look at their safety, their ability to care for themselves, because it truly does need to be a danger to self or others. Like if somebody if they yeah, it has that is the standard that comes up. Let's go into the Hunter Graham case. So there is a trigger warning. Hunter is a young man that I believe is diagnosed with a psychotic disorder, and he did unalive his mother. The family was trying to get him help and support, but his family is really working now to try to get him the help and support that he needed. All right, so let's go into this one. Oh, yeah.
We hear from you often asking, how can we collectively help care for people with mental illness? It's clear something isn't working. The reality is this: Oregon has effectively criminalized severe mental illness over the last 5 years, waiting for someone to commit a crime before they can be mandated into treatment. That's led to.
So I think that is the bigger problem right now, is that in this particular state, you have to you have to commit a crime in order to be mandated to treatment. And that's the way that the news anchor is presenting it. I'm not exactly sure, because my understanding of the law in that state is that it was that imminent risk was the only thing that was the standard for somebody to be committed or mandated to treatment without their approval.
To dangerous and devastating results. From his Southwest Portland home, Hunter Graham watched the mental health of his son Austin go downhill.
He thought that they were poisoning the air and poisoning the water and were trying to kill him. At one point, he thought somebody was hiding in the bushes in front, and took a kitchen knife and went out to investigate. And so we were concerned.
Austin's parents first started noticing mental changes when Austin went to college. He couldn't finish his biomedical engineering.
Okay, so we're starting with Austin. I believe they're going to talk about Hunter. I think I could be wrong. I was almost positive that they were going to talk about, unless I got the, I hope I didn't get the name wrong. Me and names.
Degree and moved back home. After a bad fall, it got worse.
So it's been really hard to tell whether his struggles were from pre-existing mental illness or as a result of the concussion, or a mix of both.
Last year, Austin started secluding himself in his room.
Rotting food and, poor hygiene.
Was he resistant to care?
Yes.
The Grahams needed help.
Immediately, we discovered, asking around, what you've discovered in your reporting, which is involuntary commitment is almost impossible.
Austin agreed to go to Kaiser's Brookside Center, a mental health hospital, but his stay didn't last long. He grabbed a nurse's badge and ran away from the locked unit, disappearing in the woods for 2 days.
There was going to be no way to break the cycle without medication. But we were told that it was unethical to medicate him in his current state because he wasn't in imminent danger to himself or others.
There was one route left: guardianship, a hard, expensive, and time-consuming process. The Grahams went to court, explaining how Austin was in immediate and serious danger, and his mental health was rapidly getting worse. A judge approved the guardianship in August, giving Austin's mom, Teresa, the power to consent to treatment. But even that is easier said than done.
And so even with mom having the ability to consent to treatment for him, it's my understanding they still had difficulty getting him to comply with the medical recommendations. And he was going downhill very, very quickly.
6'6", like me, and you just, even if you have the right to say you need to go to the hospital, if he refuses, then that's a significant logistic problem.
Even while under guardianship, doctors could observe Austin but couldn't force him to take medication. He didn't reach Oregon's high legal standards for involuntary treatment. Despite his psychosis, doctors said Austin was a low risk of harm to himself and others, and they sent him home with a plan.
My wife, in her wisdom, did not want him released because we knew he was going to fail. The behavioral health plan was set up to fail.
The plan did fail. Last October, while suffering a psychotic episode, Austin strangled his mother to death in their family home. Hunter Graham wasn't home at the time.
Unfortunately, the failure was that he killed her.
Initially, police saw no signs of foul play and didn't suspect Austin. 2 weeks later, Hunter was at the hospital with Austin when his son called 911.
He called police and confessed.
After police arrived, Austin wrote, "I killed my mom and strangled her with my bare hands," on the back of a sheet of paper.
Had you been worried about something like that, seeing your son's mental degradation?
We were concerned, but also relied on what the hospital evaluation was, that he was a low risk.
Teresa and Hunter Graham had been married for 33 years. She was an endocrinologist, a researcher helping people with diabetes and osteoporosis. She's described as having the rare combination of very high intellect with an even bigger heart.
I considered us very fortunate. She is a doctor. I'm a lawyer. We have resources. And even with all that, we failed spectacularly.
Police arrested Austin. He was charged with murder and is now being held and treated at the Oregon State Hospital after a judge found him mentally unfit for trial.
You shouldn't have to commit murder to get mental health care. But that's what our son Austin did to my beautiful wife, Teresa.
Hunter visits his son at the state hospital. Heartbreaking visits for many reasons.
With treatment, he's much better. I saw him yesterday in Salem, and the problem with being much better is he realizes what's happening and what's going on.
It feels to you that Oregon's system is designed to wait for something terrible to happen before getting someone care.
Treatment would have undoubtedly, in my mind, prevented this. She tried to take care of Austin and was still trying up until the end.
Hunter Graham isn't alone, and I want to say it's a testament to who he is that he was willing to talk with me and share his story to hopefully help others. But he's not alone, because I've talked with other families who've experienced tragedy as well, including the
And so this report goes into another family that has a very similar story as well. And the thing with the risk assessment, so a risk assessment, it's not 100%. That's really, now it should be a formal process, and an individual can not be completely forthright, or like things can be missed in the midst of a risk assessment. And it's just, I think there were maybe concerns that he hadn't been aggressive in the past, and that might have been why the hospital thought that he was, or the doctors thought that he was a lower risk. The goal is to treat people in the lowest level of care possible. So, the lowest level of care is typically outpatient therapy that's once a week or every other week. That is considered typically to be the lowest level of care. A step above that might be intensive home based therapy, or some type of intensive outpatient therapy, where maybe you're going 3 to 5 times a week. That would be kind of a higher level. A level above that would be an acute or short term psychiatric hospitalization. That's typically anywhere from 3 days to maybe 2 weeks or so, where the goal is medical. The goal of an acute stabilization is to get the person to a place where maybe they're on the correct medication, and maybe they have um, maybe there's some resources that can be put in place during that time. An acute hospitalization won't treat something that is chronic or long term. So that's where residential treatment. So that's where a person goes for treatment for 6 months, a year, sometimes up to maybe a year and a half. And there are some individuals that have serious mental illness where they are they end up in like a state facility. And so it sounds like Austin was placed in a state facility. And I saw Sarah, because I know Sarah is in Oregon, and had talked about um, that there might have been some issues in the past with that particular hospital, because they mentioned, I think, Salem as the hospital. Um, and this, because higher levels of care like residential, there can be, because a higher level of care is going to do things like physical restraint. The levels of medication, in my experience, people are often highly medicated, almost over medicated sometimes. Sometimes when people discharge from that higher level of care, sometimes they're able to come down off maybe the sleep medication, or like I've seen people come out of situations like that very, very, very medicated, very sedated. And yes, okay, good. I'm glad I'm not the only one. And I used to work at a residential treatment facility when I was in graduate school. I only lasted for 6 months. I worked weekends there, and then I eventually went to overnights. Overnight was easy because the kiddos slept. They just slept all day, and I was able to study and work on my graduate stuff. But it was a very, very difficult position because our main goal was to make sure that the residents stayed safe. And I worked with the youngest group of kids, not realizing that the absolute youngest kids would be the ones that have the most behaviors. I get that now as like a as a more mature psychologist, but this was when I all I had was a bachelor's in psychology, and I didn't have a lot of a lot of experience. And so um after leaving that position, I worked community mental health. I was a therapeutic mentor, and then I worked my way up to being a intensive in-home therapist, where it was our goal to help maintain people safely within their home if they could be. So if there was a crisis, if there was a major situation, that we could go and support. I did have clients that were not able to be safely maintained in their home, and we did have to look at residential or more long-term or more intensive treatments. Those are things that can happen. I know some with some medication, sometimes they end up being prescribed like a shot, because sometimes with a diagnosis like schizophrenia or with some diagnoses, taking medication regularly can become a bit of an issue or a concern. Sometimes people will run into where insurance won't pay for certain medications or for some treatments. And that just baffles my mind. Um, all right. And so let's see. Somebody asked a great question, because as we talk about these cases, sometimes it comes up, and not the Austin Graham case, but in some other cases it comes up, is the person malingering, or are they telling the truth? Are they faking mental illness? So I covered the Dejan Anderson. She's the one who is accused of unaliving her 5-year-old. She believed he was a 100-year-old demon. And like she in court, she has made the claims that she is in her 60s when she's actually in her late 30s. And she now believes that her lawyer is the grandson of Joe Biden, of President Joe Biden. And there's no indication that any of that is accurate or true. And so in the comments, people are asking, do you think she's telling, like, do you think she's really psychotic? And of course, I'm just giving my like, um, the things she's because normally when people fake mental illness, they do something like Letitia Stout, where they like pretend that they're talking to somebody else. The things that she's doing are very strange and odd, and it's not something that I've personally seen before. And that's where I think having a real thorough assessment, and she's been court ordered to complete 2 mental health evaluations to determine if she's competent to stand trial, if she's competent to represent herself. If I can give my prediction, I don't believe she's gonna be found, like, if she participates with those evaluations, I don't think she's gonna be found competent. She's probably gonna refuse those evaluations because she's already written to the court and said that those evaluations violate her rights, which those evaluations are actually trying to protect her rights. And so, it's a whole thing. So here are 2 individuals. So I found this video, and neuropsychological testing is just I do psychological testing where I do cognitive, personality. I do these different types of testing, and for both psychological and neuropsychological testing, the client's participation is really important. And there are certain behaviors that I watch out for is this person faking symptoms? Every test has error, and I can never know if somebody is giving me 100% of their effort, but there are certain tests to try to see, and these are really used within forensic settings, especially in cases where a person has a legal benefit to feigning or faking mental illness, because that definitely does happen. And so the evaluator goes in skeptical of, is this person truly experiencing these symptoms? Is there any evidence that they might be faking or malingering? And so I thought these two individuals did a good job talking about this. This is on I believe Dan Gardner. So in researching this, I found this video. Let's take a look.
What about truthfulness? What about if someone's either consciously or unconsciously exaggerating or not telling the truth? How does the testing show that?
Okay, so we're talking about neuropsychological testing is what I call client or patient driven, which means that you need the focus and the cooperation of the patient. Not so much for an imaging technique, right? If you're doing an MRI, as long as you keep from moving around, that MRI is going to take a pretty valid picture of whatever area of the body that is being imaged. But if you do neuropsychological testing, and I come across this a lot because I do a lot of medical legal work, that people who are plaintiffs in cases may have a vested interest in looking like they're performing more poorly than they really are. And so I give them a memory test. What's to keep them from performing more poorly than they're capable of doing? Okay. What's to keep them from offering more complaints or more severe complaints than they really have? So there's always this question of effort as well as maybe symptom magnification. So we have to look at that. Symptom magnification is something where people give more complaints, whether they are real complaints that they're just magnifying or false complaints, whatever. And generally, we have a number of questionnaires in which we have validity scales. And
All right. And so he said a whole bunch very quickly. And what I want to break down is that psychological or neuropsychological testing is client driven. So I've had somebody come in and refuse to do the testing. I cannot assess them if they refuse. And they have to talk, they have to engage. There are nonverbal assessments, because let's say I have somebody that is coming in. So I have worked with people that were on the severe end of the autism spectrum, where they could not speak verbally, they did not have a communication device. And so I did have to give a 100% nonverbal test. And their ability, they did not have the ability to be verbal. So it wasn't that they were refusing or not complying, it was just they weren't able. So I was able to assess their nonverbal ability. And so there are specific validity tests to see, is somebody faking good? Is somebody denying symptoms that they actually have? Or is somebody faking bad? Is somebody saying they have all these symptoms, and the chances of them actually having all those symptoms is very, very rare. There is a such thing as a cry for help um like profile, where and that's typically on things like the MMPI or the personality assessment inventory, the PAI. There is a profile where sometimes especially individuals with borderline personality disorder, or individuals that are in high crisis, in high conflict, that truly are having a lot of like, this is the person that's just trying to get help. They're saying, "Yes, I have everything." And they're really just trying to get help and support. There isn't some additional motivation of theirs legal involvement with court or custody evaluations. It's really common to get that fake good, where the person is denying having any symptoms at all, but they're also denying things that most people would admit, because they're trying to look overly good, because the evaluation is being used for court, like for custody purposes. And so let's listen to a little bit more of this.
that something like the MMPI. The MMPI is just one example of a number of personality tests that are distinguished, not only that they look at some complaints, they also look at whether a person may be exaggerating or magnifying, or actually trying to deny problems. So to a certain extent, we can rely on those scores to see whether or not there's magnification or what we call over-reporting, or there's minimization, or what we call.
I want to point out the fact that neuropsychological testing is really intense and really invasive. Sometimes it takes 2 to 3 sessions to complete all of the neuropsychological tests. I just do the general psych. My assessment of just the testing typically takes between maybe an hour and a half to maybe 3 hours. Possibly, I have had some cases where it was where the person needed multiple breaks or they weren't able to complete everything all in one session. But neuropsychological testing is very intense, and yes, it is a lot, but it does dig deeper. So if people are looking into um just like if they're looking for a diagnosis of dyslexia, or if they're looking at like the type of processing disorder that they might have, typically neuropsychological testing will be used because it does just dig deeper into all of those functions versus a general psych. Most people can just do a general psych if they're just looking for a diagnosis of like ADHD, bipolar disorder. If they're just looking for a general diagnosis, sometimes if people have had head injuries, or if they've had some, like if they've had a stroke, or if they've had seizures, sometimes a neuropsychological is more appropriate just because of it does look at the functioning of different areas of the brain.
Underreporting. That's different than effort. All right. So how you perform on a test is not a question of whether you're magnifying or not. It's whether you're trying or not. And so there are certain things we see in people who are not trying that are patterns that are pretty typical of people who are not trying. And there have been a number of tests that have been developed that capitalize on these principles. And lots of times are referred to tests of malingering, but malingering is nothing that you can pick up from a test. All you can pick up from a test is that someone is not performing up to expectations. Maybe malingering is what the issue is, but maybe, as we talked about before, maybe they're anxious, maybe they're depressed, maybe they're sick. There could be a number of things.
And so instead of calling it malingering, some people will call it test of effort, that there are some tests that are evaluating the person's effort.
Our test results, there are certain test scores, certain test patterns that we could look at that we say, you know what, this person is likely not performing up to their capabilities. But unless you have some very specific patterns that are basically very specific to malingering, all we can do is hope to say that they're underperforming. It's then up to the clinician to put it all together and determine why.
I hope you like this video.
All right. And so that case, because somebody mentioned that so with the biopsychosocial model, which is that like biology and our environment and then stress can sometimes impact what symptoms present. Sometimes what can happen is a stressful event can sometimes trigger a some type of psychotic episode, or like if there is schizophrenia that runs in the family. um, but sometimes people can have a head injury that damages a particular part of the brain, or after that injury, the brain overproduces dopamine. So a lot of the antipsychotics are about reducing the levels of dopamine in the brain. Because that overproduction is often what we believe can cause psychotic symptoms. There are lots of different antipsychotics that look at different neurotransmitters. Those are I'm not a medical doctor. That's just my general knowledge, my general information on those topics. So, a psychological and neuropsychological, it gets really invasive, and I warn people like, hey, some of these questions are going to be really strange. Some of them are not gonna apply at all. Some of them might, and for people to just answer as best they can. So I um I wouldn't call it faking, so the language within the testing write-ups is like a fake good or fake bad. But often people will talk about it in terms of effort. One of my favorite people that talked about this was Dr. Curry during Amber Heard's trial. When Dr. Curry was discussing Amber Heard's uh, profile that she gave, and then also reviewing the results of the other psychologist as well. And so yes. And there are so I've had a lot of evaluations where somebody that has like complex trauma, or somebody that's presenting they have a lot of symptoms. It can sometimes flag that fake that fake bad, or it can sometimes flag that cry for help profile. And when I'm interpreting the results, sometimes I take a look at it in the scope of the whole profile. So that's why if somebody just does the MMPI, like it has to be interpreted like with a clinical interview, and it has to be considered within like a whole holistic view of the person. Because also sometimes people, they read the question wrong. Like, and or did they like lose attention? So the MMPI, I don't give it because I think it's over 500 questions. So I personally give the PAI, because the personality assessment inventory, because I think it's around 300 questions. I also give that to teens as well, because I think that one is like 260 or so. Yes, yeah. So, and also the reading level for the PAI is lower. The and I hate for the MMPI that it's forced true or false. Like that's the MMPI is very dichotomous to me, and I'm not a big fan of that. So I haven't given an MMPI since graduate school. Like I don't give them. If somebody's calling around because they need someone to give them an MMPI, I would refer them to somewhere else. Um I don't personally give it. I prefer the personality assessment inventory. Like I said, the reading level is a little bit lower. It offers like false, sometimes true, mostly true, and very like it offers like four different options instead of that true or false. And so that's my personal thought. Um Rachel Ann, 3 hours. I am not surprised that it took so long to do, like, the MMPI. It is a long test. I think I took an hour and a half. We had to take them in graduate school. So all of us, because in learning to interpret it, we had to, like, give it to ourself, and we just I don't know, like, but we did that in graduate school. And then also to just understand what it's like for a client to sit down and take it. But yeah, it's very black and white, like you're saying, Sarah, always or never. That's why I don't, because like to read a question and be like, is this true or false? Oh, like that's so much. For anybody that's a member, so I added a new so member, so please like the video, subscribe. You only the free things are fully like I appreciate it so much. I added a 299 membership versus the 499. Um when I first said it, it was just like, "Oh, let me just set it." Thank you to anyone that supports the channel. Thank you, Trinette, for becoming a member. Thank you to Lavender Lush, and then Bonnie. Thank you for addressing this. You've answered a lot of questions. I'm glad that this was helpful, because the civil commitment process is very complex. It's very difficult, and sometimes I think the hospital and the family, and because you really are taking away somebody's ability or right to like their autonomy. And in treatment, autonomy is really important. If I have a client that I believe needs to go for a psychiatric assessment, I'm really, really concerned about their safety. 9 times out of 10, I get them to agree to go for the assessment. I've rarely had to have someone, um, now the younger the child. So there were times where then I talk with the parents, and if the parents aren't comfortable with maintaining the child's safety, there are times when I've had to have clients go to the ER for an assessment. It's always my goal, if I can avoid hospitalization, because some people get worse in those institutions, or some people function really well in that institutional setting and then they don't transition out well. So, our community services board. So, most states, I think, have community supports or community services available. It's going to differ by state, but there are some states that offer group home settings, that offer where the staff are trained and the people are being monitored. They are required to take their medication. Excuse me. And then they track if they're refusing their medication. I've also seen some doctors and psychiatrists not fully listen to the families, which is really heartbreaking, because to me, those families know their loved one the best. And Sarah, thank you for being a member for 11 months. Like, I think I've only had my membership available for like a year. So you must have been one of my first members. I had my anniversary of the channel being monetized, I think back in March. Um, I think it was the Murdaugh trial. I had one of my Murdaugh videos do well, and that was hilarious. Not hilarious, but like, so the hilarious part for me was that it was just Judge Newman talking. Like, it was like, but people were looking for, Judge Newman, and I reacted. I said some stuff, but I thought that was absolutely hilarious. Yes, yes, celebrating that little anniversary. Um, Lisa, the hospital, the doctors did not feel like he was an imminent risk. So imminent risk is, I think it's going to happen in the next 12 to 20, like, I think it's going to happen immediately, because they probably asked him, "Are you gonna harm yourself?" He probably said, "No." "Do you agree to safety plan?" I know in my state, if somebody will agree to safety plan and then the family says, "Okay, we'll lock up the sharps, we'll do this, we'll do that," people can often go home if the person agrees to safety plan. Most therapists don't do those don't unalive yourself contracts. I remember I was trained, I think, in grad school. So I'm old. I'm almost 42, I think. I don't know. 40. I don't know. I don't know how old I am. Um I'm in my 40s, and but I know I'm not 60. I know I'm not. I don't know how she said she was 60. Whole other conversation. But we were trained to do those, like promise to not unalive yourself by next session. I no longer do those because I did additional training, and those aren't particularly helpful. I do safety plans instead. And what a safety plan is we identify the person's triggers, we identify their supports. Sometimes what happens is, if I'm working with an adult, they agree to give their weapons, or they agree to like have a family member come in. They maybe go and stay with a family member. We just monitor safety that way. And it sounds like Austin was psychotic, and there were probably times that he was connected with reality, because if you look at even that case of Dejon Anderson, to me, there are moments where she seems perfectly fine. There are moments where she seems like she has it together. But then if you start listening to her talk about her delusions and all of that stuff, that's when you're like, ooh, like, I don't think she should have had, ooh, like, somebody should have come in to make sure that her child was okay. And so, um, yes, you can be admitted on an involuntary hospitalization, and that is where the therapist, maybe the family, thinks the person should go. In my state, you get a court hearing within those 72 hours. It's typically business days. I don't think it's like actual hours. So an officer can put the person in their custody. That's sometimes what happens. Let's say there's a crisis, a mental health crisis at someone's home. They call mental health services, and an officer is there as well, and the person is, if they're stable enough to be transported by the officer, then they do have to be handcuffed in my state, because they're going into the back of the police car. And so, just for the safety of the individual. And so, that's where sometimes they will try to have a family member transport them if they're safe enough to be, but sometimes they're not. I've also known people to be transported in ambulances as well, but that's only if they are safe enough. Often in my state, officers try to not take custody because that officer has to stay with that person until they find a bed. And in most states, there are shortages of psychiatric beds, of those acute psychiatric beds. So I think in the entire state of Virginia, there might be, let's say, like 150 psychiatric beds for children, but on any given night, there might be 250 kids that maybe need a psychiatric bed, which means that some people wait in the hospital until a bed comes available. And I've known situations where people have been at the hospital for days. Typically, the hospital sends them home after like 3 days, but the person has been in the hospital for days. And then when they're sent home, like, it's just like, hey, if things get worse, come back and we'll see if a bed is available. We really do have issues in our nation with mental health. Oh, before we go, can you please explain the logistics on forcing meds on a patient or client? I know that all meds are not all meds are able to be dispensed via IV. And so the forcing part is just that they are court ordered to do it. So I've worked with some cases where the child was court ordered through a CHINS petition, a child in need of supervision or services, and if that child was not compliant with their medication, then they might have like legal repercussions. Like, the parent could get support from the probation officer, from their social worker. Like, there were supports in place for somebody that was determined that they needed to be on their psychiatric medication. Even in a psychiatric hospital, people are able to refuse their medication. If somebody is escalated, that is where that consent, where they are no longer able to consent themselves, and sometimes people are administered medication in like a escalated state. And that's when people talk about, yeah, so sometimes it's injected, or sometimes I know situations where before the person could come out of the quiet room, or before they could return to the unit, they were uh, asked to take their PRN, so their as needed medication. So, um, that is my understanding of that. I don't currently work with anybody that is court ordered to take medication. Sometimes in a custody dispute. So, like, let's say one parent has severe depression and has a history of maybe unaliving attempts or something. The court order might say that that parent has to be medicated, in order to maintain visitation with the child. And so, that's what I've sometimes seen. I hope that helps. Thank you for calling me young. I love that you said I'm 44, I think. Hey, mama. Mama knows how old I am. All right, let me just make sure that I didn't miss anything. Uh, um, all right. Yeah. And so I know sometimes, like, sometimes it's antipsychotics. Hydroxyzine is sometimes one that's administered like pill wise, which, yeah, like there is a lot. Yeah. And sometimes people can experience things in in those settings. Haldol. That's what I was that was the one I was thinking of, which is like a old, like a, I think like a first generation antipsychotic, and that one will zonk a person out. Like, that one makes somebody like That one is very, very strong. Worked with clients on conditional release, and they were mandated to stay on their psychotic medication. And we talked about mandated, what was that? Conditional release with the case of the Slender Man. So I covered one of the girls from the Slender Man case because there's one girl that one she's a woman now who is still in a state facility. The other individual who was also involved in in the attack on the friend, she was released when she was around 19 years old on that conditional release. And if she was prescribed medication, she likely had to take them. Um, this is a great question, and, there are lots of things that can cause psychosis, and so the biggest thing about schizophrenia is psychosis. So somebody can have autism. So normally schizophrenia is gonna come up as an adult, whereas autism, you're gonna see signs and symptoms since early childhood. There are some cases, especially if two parents have schizophrenia, or if there is like a parent that had schizophrenia, there are cases of kids as young as like 6, 7, 8 showing signs of schizophrenia. But in my experience, um, individuals that have schizophrenia. So schizophrenia can sometimes have that social awkwardness, that disconnect from social situations and settings, but it's not developmental. So with autism, that would be a developmental disconnection, and it can be difficult to parse out. So I hope that helps. All right. So there can be pediatric cases of schizophrenia. There can be. I've worked with people that were diagnosed younger than that. They often had histories of significant trauma. I've also seen people misdiagnosed with schizophrenia. Schizoaffective disorder. So that is where somebody has signs of bipolar disorder or significant depression, major depression, and then also has schizophrenia, and there is a gap in their symptoms. Schizoaffective disorder is very difficult to diagnose. They often diagnose those within those residential settings because they're able to see them over a long period of time. African Americans were overdiagnosed with schizophrenia early on when maybe the individual might have had like something like bipolar disorder, or they might have had some other condition. So sometimes if somebody says that they were diagnosed with schizophrenia in the 70s, I dig deeper for those symptoms because African Americans, we know we're overdiagnosed with schizophrenia before the 90s, I want to say. And there are some communities where there isn't a really good family history of mental health, where because mental health services weren't accessible back, during those times. And so yes. Yeah, yeah. And so often when it's schizoaffective, the person often gets diagnosed with schizophrenia first. And that's what I've seen. Or sometimes bipolar disorder with psychotic symptoms. But then you realize it's actually schizoaffective disorder. And the diagnosis just helps direct treatment because somebody with schizophrenia and like a bipolar disorder, we know to monitor for those manic episodes. Like we have to regulate both things because typically, if somebody has bipolar disorder with psychotic features, you often can just treat them with a mood stabilizer and they might not need to be on like a heavy antipsychotic. And so, um, uh, racism, like why? I don't. I'm not laughing because it's funny. Like that's legit. Like what it was. It was a way to people were also overly African Americans were overly institutionalized against their will. So there is kind of a dark history with some of these things where having a good understanding of of history and people's experiences can be really, really, really important. Sometimes experimental treatments were done without people's consent, and so that's why some individuals do not trust therapists, do not trust the system. They will only see people that are culturally aware, which I get it. All right. Um, Let me see. Ah, and then somebody mentioned that a cousin's schizophrenia started after a brain injury where they lost oxygen to the brain for too long, and that is, yeah, wow. And people can live well with these conditions. So, with schizophrenia, what we have to watch out for is paranoia. We have to watch out for delusions. Sarah, I saw your question from yesterday's live. I didn't tell y'all. So, I actually had like a little panic attack at the end of the video yesterday. Like, I felt I was like, I'm either having a heart attack or a panic attack. Let's get off the live and not like traumatize all y'all. And so I got off and it simmered down within like the normal 2 minutes. So I was like, oh, that was a panic attack. I was fine. And so I get them maybe once or twice a year. It's not something that's frequent. But I saw your question about paranoia and delusions, and some people can sometimes have both. So do I see clients with IED? Let me see what that is. So I don't always. Oh, intermittent explosive disorder. So I don't give that diagnosis a lot. So intermittent explosive disorder is sometimes when somebody doesn't fit neatly into another category. So if somebody did come with that diagnosis, yes. I haven't seen a ton of people with that particular diagnosis. I know when I was in graduate school, somebody tried to give that diagnosis, and yes, and so mental health affects all cultures. All like mental health is something that affects everyone, and what's happening now is in the past marginalized communities like African Americans, people that were from the Latina, Latinx community, there were some people that were protected against things like unaliving themselves. They just didn't do it. They didn't do it very often. Now what we found is more, especially in younger children, but also young adults and adults as well, we're seeing instances where like race is no longer a protective factor for thoughts or completing um suicide. And so and racial trauma can be a big trigger for that. Also trauma and depression, hopelessness, those kinds of things. And so, ooh, and I live in Virginia, and I've worked at a few of them. So I did my internship at Virginia Treatment Center for Children, and so yes. All right. Uh, and I will not name the other hospital that I worked at because I did not like it. They were not trauma informed. Yes, and so this is true. African Americans in general, but in particular African American boys, often get misdiagnosed with oppositional defiant disorder, and people miss signs of autism. Girls are often get a later diagnosis of both ADHD and autism, but and then so then Black girls often get late diagnoses of autism as well. So when two kids present with the same behaviors, where the child is very rigid, they're having difficulty following rules, they're maybe having explosions, and they're getting really frustrated in the classroom. If it is a little European American boy, they get a referral for a psychological. The psychologist sees signs of autism, they get diagnosed. The same little that happens, and it's a little African American boy, that child gets diagnosed with oppositional defiant disorder, which is why I do not give that diagnosis. I just don't. I have given conduct disorder before, because that's when individuals are involved with the justice system and there are like other symptoms, there are other things going on as well. But oppositional defiant disorder is one that is overdiagnosed in African American boys. And often what it is the whole system looks at this kid needs discipline and this other kid needs treatment when actually both kids need treatment. And so depression in kids often comes out as anger and aggression, and it can come out as in acting out behaviors. And so that's where kids can get misdiagnosed. These are the reasons why I accept Medicaid. I don't accept every Medicaid plan, and I'm not accepting new clients. I don't say that for that reason. I say that because I really enjoy being able to provide a safe place for people, and to dig deeper into their actual diagnosis. I'll never forget. I've had multiple kids come into my office, very defiant, very guards all the way up, and I just don't respond to it. Like they come up with the guards. I already have my boundaries in place. I give them choice, and we end up working together. And then we find out that there's significant anxiety, that there's undiagnosed ADHD. Um, I've had families come back to me and tell me, "Oh, wow, like, after we started our child on the appropriate medication, like, their anxiety is like like, they're not anxious about doing their work anymore because they can think." And, like, it's just super, super cool to see. Um, yep. Alright. And so, um, I'm glad that we were able to chat about these things. And this is just the end of today's stream. I'm so glad that I got to chat with you all about these topics. If there are things that you would like for me to cover, please let me know. I am keeping a close eye on the Chad Daybell trial. We might cover, so depending, because there have been some juicy things happening. So if I can wait until next Saturday, we might talk about that one next week. But if I can't wait, then I'll do a pop-up live sometime this week. So thank you again to the person that recommended it. I'm glad that we were able to talk about this process, and I hope you all enjoy the rest of your day. Bye.